Specific hernia types. Hernia sites are shown in figure 60.9 over here. Diagram to show the sites of abdominal wall hernias, common in red and rare in black. Incisional and parastomal hernias can be found at various sites. So over here on the ventral side we have epigastric, paraumbilical, umbilical hernia. These are the common hernias, and below inguinal and femoral hernia are the common ones. On the back, all the hernias on the back are rare, that's superior lumbar, inferior lumbar, gluteal and sciatic. Anteriorly we also have some rare hernias like Spigelian hernia and obturator hernia. These are the sites of hernia. Now we'll move and see the hernias. Inguinal hernia. Inguinal hernia, often referred to as a rupture by patients, is the most common hernia in men and women, but much more common in men. There are two basic types that are fundamentally different in anatomy, causation and complications. However, they are anatomically very close to each other. Surgical repair techniques are very similar, and ultimate reinforcement of the weakened anatomy is identical. So they are often referred to together as inguinal hernia. Inguinal hernia types: there are lateral, that's oblique or indirect, and medial, which is direct and sliding. Origin: congenital or acquired. Anatomy: inguinal canal. Classification: latest European Hernia Society. Diagnosis: usually clinical but radiological is in special circumstances, and surgery: open or laparoscopic. The congenital inguinal hernia is also known as indirect, oblique or lateral, whereas the acquired hernia is called direct or medial. There is a third sliding hernia that is acquired but is lateral in position. So basic anatomy of the inguinal hernia: as the testis descends from the abdominal cavity to the scrotum in males, it first passes through a defect called the deep inguinal ring in the transversalis fascia, just deep to the abdominal muscles. This ring lies midway between the anterior superior iliac spine and the pubic tubercle, approximately 2 to 3 centimeters above the femoral artery pulse in the groin. The inferior epigastric vessels lie just medial to the deep inguinal ring, passing from the iliac vessels to the rectus abdominis. Muscle fibers of the innermost two layers of the lateral abdominal wall, the transversus muscle and the internal oblique, arch over the deep inguinal ring from lateral to medial before descending to become attached to the pubic tubercle. These two muscles fuse and become tendinous, hence this arch is referred to as the conjoined tendon. Below this arch there is no muscle but only transversalis fascia and external oblique aponeurosis, resulting in weakness. This is shown in 60.10. We can see this over here, the close relationship of direct inguinal hernia and indirect inguinal hernia and femoral hernias. There is iliacus muscle, and from the lateral to the medial side we have femoral nerve, femoral artery, femoral vein. Then there is a sac of femoral hernia, and we can see the two hernias. The below one is the sac of direct inguinal hernia, and the upper one is the sac of indirect inguinal hernia. We can see the inferior epigastric vessels above and the internal inguinal ring, and this is the external inguinal ring. The testis proceeds medially and downwards along the inguinal canal. Anterior to the canal is the aponeurosis of the external oblique muscle, the fibers of which run down, and medially the testis finally merges through a V-shaped defect in the aponeurosis, the superficial inguinal ring, and descends into the scrotum. The inguinal ring is roofed by the conjoined tendon. Its posterior walls is transversalis fascia, and anterior wall is external oblique aponeurosis and a floor, which is also the external oblique, that rolls inwards in its lower margin and thickens to become the inguinal Poppard's ligament. The inguinal canal in males contains the testicular artery, vein, lymphatics and the vas deferens. In females, the round ligament descends through the canal to end in the vulva. Three important nerves, the ilioinguinal, the iliohypogastric and the genital branch of the genitofemoral nerve, also pass through the canal. As the testis descends, a tube of peritoneum is pulled with the testis and wraps around it, ultimately to form the tunica vaginalis. This peritoneal tube should obliterate, possibly under hormonal control, but it commonly fails to fuse either in part or totally. As a result, bowel within the peritoneal cavity is able to pass inside the tube down towards the scrotum. Inguinal hernia in neonates and young children is always of this congenital type. However, in other patients, the muscles around the deep inguinal ring can prevent a hernia from developing until later in life when, under the constant positive abdominal pressure, the deep inguinal ring and muscles are stretched and a hernia becomes apparent. As the hernia increases in size, the contents are directed down into the scrotum. These hernias can become massive and may be referred to as scrotal hernia. An indirect hernia is lateral because its origin is lateral to the inferior epigastric vessels. It is also oblique as the hernia passes obliquely from lateral to medial through the abdominal muscle layers. The second type of inguinal hernia, referred to as the direct or medial, is acquired. It is a result of stretching and weakening of the abdominal wall just medial to the inferior epigastric vessels. Looked at from within the abdominal cavity, there is triangle referred to as Hasselbalch's triangle, the three sides of which are the inferior epigastric vessels laterally, the lateral edge of the rectus abdominis medially, and the pubic bone below the iliopubic tract. This area is weak because the abdominal wall here consists of only transversalis fascia covered by the external oblique aponeurosis. A direct medial hernia is more likely in elderly patients. It is broadly based and therefore unlikely to strangulate. The medially placed bladder can be pulled into direct hernia. The third type of inguinal hernia is referred to as the sliding hernia. This is also an acquired hernia due to weakening of the abdominal wall. It occurs at the deep inguinal ring, lateral to the inferior epigastric vessels. Retroperitoneal fatty tissue is pushed downward along the inguinal canal. As more tissue enters the hernia, peritoneum is pulled with it, thus creating a sac. However, the sac has formed secondarily, distinguishing it from a classic indirect hernia. On the left side, sigmoid colon may be pulled into a sliding hernia, and on the right side, the cecum. Surgeons need extra caution during repair because the wall of the large bowel may not be covered by peritoneum and can be damaged. Occasionally, both lateral and medial hernias are present in the same patient, that is known as pantaloon hernia. Over here in the figure 60.11, we can see a huge scrotal hernia that has descended into the scrotum. The overlying skin has become gangrenous and slurped away. And in figure 60.12, laparoscopic view of the posterior inguinal region with hernia defects highlighted. Yellow is the medial inguinal, blue is the lateral inguinal, and green is the femoral hernia. And between the yellow and blue, we can see the inferior epigastric vessels. Figure 60.13, this cystogram shows the urinary bladder part which has descended into left direct inguinal hernia. Classification. Many surgeons over the past 100 years have attempted to classify inguinal and femoral hernias, including Castin, Halverson, and McVeigh, Zollinger, Ponca, Gilbert, and Nihus. The European Hernia Society has recently suggested a simplified system. First, primary or recurrent, it's either P or R. Lateral, medial, or femoral, whether it's L, M, or F. Defect size in finger breadths assumed to be 1.5 centimeter. A primary indirect inguinal hernia with a 3 centimeter defect size would be, for primary it's P, for indirect it's lateral, that is L, and for hernia of 3 centimeter it's 2, because 1 is 1.5, then it's 2, 2 into 1.5 is 3. Diagnosis of an inguinal hernia. In most cases, the diagnosis of an inguinal hernia is simple and the patients often know their diagnosis because they are so common. Usually these hernias are reducible, presenting as intermittent swellings lying above and lateral to the pubic tubercle with an associated cuff impulse. Often the hernia will reduce on lying and reappear on standing. With the patient lying down, the patient is asked to reduce the hernia if it has not spontaneously reduced. If the patient cannot, then the surgeon gently attempts to reduce the hernia. Once reduced, the surgeon identifies the bony landmarks of the anterior superior iliac spine and pubic tubercle to landmark the deep inguinal ring at the mid-inguinal point. Gentle pressure is applied at this point and the patient asked to cuff. If the hernia is controlled with pressure on the deep inguinal ring, then it is likely to be indirect or lateral, and if the hernia appears medial to this point, then it is direct or medial. Other examination techniques have been suggested, but even experienced surgeons find it difficult to distinguish lateral and medial hernias with certainty. This figure 60.14, we can see the oblique left inguinal hernia that became apparent when the patient coughed and persisted until it was reduced when he lay down. Moving diagnostic difficulties. What are the diagnostic difficulties? Confirmation of the diagnosis may not be possible when the patient describes an intermittent swelling, but nothing is found on examination. Surgeons will often accept the diagnosis on history alone, but re-examination at a later date or investigation by ultrasound scan may be requested. If an inguinal hernia develops irreducible and tense, there may be no cuff impulse. Differential diagnosis would include a lymph node groin mass or an abdominal mass. Such cases require urgent investigation by either ultrasonography or CT. Large scrotal hernias may be misdiagnosed as hydrocele or other testicular swellings. The surgeon should be able to identify the upper limit of the scrotal swelling, but a large scrotal hernia has no upper limit because it extends back along the inguinal canal to the peritoneal cavity. In cases of doubt, ultrasonography should establish the diagnosis. As inguinal hernia is so common, less experienced clinicians might suggest this diagnosis when referring cases of femoral hernia or spigelian hernia. Also, patients with a sphena varix may present with a swelling that increases in size on standing and with a definite cuff impulse and be misdiagnosed as a hernia. The same can be true for a varicocele. It is essential to examine the scrotal contents to exclude other pathologies and to check that the patient has two testes. It is important to examine the opposite side because contralateral hernia is common. Even if the contralateral side is weak, then bilateral repair should be recommended because the risk of contralateral recurrence is high. Of all patients, 10% will present with bilateral inguinal hernias and up to 20% more will have an occult contralateral hernia on laparoscopic evaluation. A patient with a single hernia has a lifetime 33% risk of developing a hernia on the other side. Some surgeons have suggested that all patients should be offered bilateral repair, especially if laparoscopic surgery is planned, but this is not widespread practice at present. And this 60.15 is the malignant mass of nodes. This is the differential diagnosis which you can look out for while having an hernia patient. Investigations for inguinal hernia. Most cases require no diagnostic tests, but ultrasonography, CT and MRI are occasionally used. A herniogram involves the injection of contrast into the peritoneal cavity followed by screening, which shows the presence of a sac or asymmetrical bulging in the inguinal anatomy. Management of inguinal hernia. It is safe to recommend no active treatment in cases of early asymptomatic direct hernia, particularly in elderly patients who do not wish for surgical intervention. These patients should be warned to seek early advice of the hernia increases if the hernia increases in size or becomes symptomatic. Surgical trusses are not recommended but may be required for occasional patients who refuse any form of surgical intervention. Elective surgery for inguinal hernia is a common and simple operation. It can be undertaken under local, regional or general anesthesia with minimal risk, even in high-risk patients. Herniotomy. What is herniotomy? In children who have lateral hernias with persistent processes, it is sufficient just to remove and close the sac. This is called herniotomy. In adult surgery, herniotomy alone has a high recurrence rate and some form of muscle strengthening is added, herniorrhaphy. Now, open suture repair. What is open suture repair? In 1890, Eduardo Bassini described suture repair for inguinal hernia. You can see in 60.16, this is the Bassini's original diagram, in which A towards the left side is the subcutaneous fat, B is the external oblique aponeurosis, C is the iliac vein, for E we can see the spermatic cord, F the nerves in the inguinal canal, and G is the transversalis fascia. This was a massive leap forward and has been the basis of open repair for over 100 years. The surgeon enters the inguinal canal by opening its anterior wall, the external oblique aponeurosis. The spermatic cord is dissected free and the presence of a lateral or a medial hernia is confirmed. The sac of a lateral hernia is separated from the cord, opened and any contents reduced. The sac is then sutured closed at its neck and excess sac removed. If there is a medial hernia, then it is inverted and the transversalis fascia is suture plicated. Sutures are now placed between the conjoint tendon above and the inguinal ligament below, extending from the pubic tubercle to the deep inguinal ring. The posterior wall of the inguinal canal is thus strengthened. Over 150 modifications of Bassini's operation have been described with little or no benefit except for the shoulder modification. In this operation, the transversalis fascia is opened by a central incision from the deep inguinal ring to the pubic tubercle and then closed to create a double thick two-layered posterior wall, that's double breasting. The external oblique is closed in a similar fashion. Expert centers have reported lifetime failure rates of less than 2% after shoulder repair, but it is a technically demanding operation which in general hands gives results identical to Bassini's repair. Today, when Bassini type operation is done, most surgeons use a continuous non-absorbable nylon or polypropylene suture which is darned between the conjoint tendon and inguinal ligament. This operation was described by Maloney. A recently published large randomized trial have reported excellent results when compared with mesh techniques. It is the most common operation performed in countries where mesh is too expensive. Suture repair is still under development, and recently the Sarda has described an operation where a 1 to 2 centimeter strip of external oblique aponeurosis lying over the inguinal canal is isolated from the main muscle but left attached both medially and laterally. It is then sutured to the conjoint tendon and inguinal ligament, reinforcing the posterior wall of the inguinal canal. As the abdominal muscle contracts, this strip of aponeurosis tightens to add further physiological support to the posterior wall. This operation is currently being evaluated. Open flat mesh repair. Synthetic mesh has been used since 1950s to reinforce hernia repair, and in the 1980s, Lichtenstein described a tension-free, simple, flat polypropylene mesh repair for inguinal hernia. It's given in figure 60.17, we will see to it. The initial part of the operation is identical to Bassini's. Once the hernia sac has been removed and any medial defect closed, a piece of mesh measuring 8 into 15 centimeters is placed over the posterior wall behind the spermatic cord and is split to wrap around the spermatic cord at the deep inguinal ring. Loose sutures hold the mesh to the inguinal ligament and conjoint tendon. Two major advantages are claimed: lowered hernia recurrence rates and accelerated post-operative recovery. Randomized trials show that hernia recurrence within the first 2 years is lowered, but acute pain scores are similar. Recent research comparing Lichtenstein's repair with laparoscopic surgery has identified chronic pain as the most common complication of open flat mesh repair, with rates reported as high as 20%. Nevertheless, today Lichtenstein's repair is the most common operation for inguinal hernia in resource-rich countries. So this was the diagram, 60.17 Lichtenstein's repair. You can see the mesh being placed. Now, open, plug or device or complex mesh repair. Surgeons and industry have been highly creative, attempting to improve on simple flat mesh repair. A surgeon in Europe has over 200 different products and techniques from which to choose. Shaped mesh plugs have gained much attention, being simple to insert into the defect and requiring little, if any, fixation. However, they can become solid, meshoma, and also migrate. Meshes have been designed to be placed beneath the transversalis fascia. The surgeon introduces a finger through the deep inguinal ring and blindly opens the preperitoneal space deep to the inguinal canal, into which a mesh is inserted. A two-layered mesh hernia system in which the inner layer is placed deep to the transversalis fascia and the outer layer superficial to it is also gaining popularity. To date, there is little evidence to show that any of these techniques is superior to Lichtenstein's operation. Open preperitoneal repair. This approach was first described by Annandale in 1880 but was largely discarded until the 1950s when Stopa, a French surgeon, described it with mesh reconstruction. It is useful when multiple attempts at open standard surgery have failed and the hernias keep recurring. It may now be superseded by the totally extraperitoneal laparoscopic approach, which is modeled on Stopa's operation and the first described by Gurr, also French. Laparoscopic inguinal hernia repair. Two techniques are described and have been extensively studied in randomized trials. The totally extraperitoneal approach, the TEP, is more widely used than the transabdominal preperitoneal approach, that is TAPP. In both, the aim of surgery is to reduce the hernia and hernia sac within the abdomen and then place a 10 to 15 centimeter mesh just deep to the abdominal wall, extending across the midline into the retropubic space and 5 centimeter lateral to the deep inguinal ring. The mesh covers Hasselbalch's triangle, the deep inguinal ring and the femoral canal. In totally extraperitoneal approach, the surgeon is able to create a space just deep to the abdominal muscles without entering the peritoneal cavity, whereas in TAPP, which was transabdominal preperitoneal. The surgeon enters the peritoneal cavity, then incises the peritoneum above the hernia defects and reflects it away from the muscles, essentially entering the same space as in TEPP. Once the hernia has been reduced, an identical mesh is inserted and the peritoneum closed over the mesh. You can see this in 60.18 and 60.19. 60.18, right or medial direct hernia, laparoscopic view. Note the medial direct defect upper left, medial defect upper left, the inferior epigastric vessels upper right, and the structures of the spermatic cord lower right. In this figure 60.19, there is the right lateral indirect hernia laparoscopic view. A is the arch of pubic bone, B is the vas deferens and testicular vessels retracted medially. They are retracted medially. Then in C is the inferior epigastric vessel, and D is the deep inguinal ring hernia. Over 60 randomized trials have compared laparoscopic surgery with lichen stents repair. They show that although the laparoscopic operation takes longer to perform, proven advantages are reduced pain both after surgery and up to 5 years later, more rapid return to full activity, and reduced incidence of the wound complications of infection, bleeding and seroma. Laparoscopic surgery is of particular benefit in the bilateral cases and in patients with hernia recurrence after open surgery. National statistics show that the proportion of cases performed laparoscopically is slowly rising, but all agree that there is a slow learning curve associated with these technical demanding operations. So operations for inguinal hernia. You've seen herniatomy, then open suture repair with Bassini, Scholdis and Sarda, open flat mesh repair lichen stents, open complex mesh repair, plugs and hernia systems, open peritoneal repair, that's Stopa, and laparoscopic repair, which is totally extraperitoneal and transabdominal preperitoneal. Emergency inguinal hernia surgery. Of inguinal hernia patients, 95% present at clinics and only 5% as an emergency with a plain irreducible hernia that may progress to strangulation and possible bowel infarction. The morbidity and mortality of emergency inguinal hernia surgery are high, and surgery needs to be performed rapidly in a well resuscitated patient with adequate post-operative high dependency or intensive care if necessary. The principles of surgery are the same as in an elective setting. Open surgery is preferred when a hernia is irreducible or if there is any risk of bowel resection. Infection may complicate these cases, but most surgeons would still use a lightweight synthetic mesh repair covered by appropriate antibiotics. Complications of inguinal hernia surgery. Despite this being a common procedure and technically straightforward, post-operative complications are common. Immediate complications include bleeding, which may be due to accidental damage to the inferior epigastric or iliac vessels, and urinary retention that may require catheterization. Occasional over-enthusiastic infusion of local anesthetics may lead to femoral nerve blockade, the patient being unable to move a leg. This usually resolves over 12 hours but is alarming. Over the next week, seroma formation and wound infection may occur. Seroma is due to an excessive inflammatory response to sutures or mesh and cannot be prevented. In most cases, the fluid dissolves spontaneously but may require aspiration. After laparoscopic surgery, a seroma may be misdiagnosed as an early recurrence. Wound infection is not uncommon. Many surgeons use routine prophylactic antibiotics, but recent studies still suggest little benefit even when mesh is used. In the long term, hernia recurrence and chronic pain are the main concerns. No operation can be guaranteed to be recurrence free. Evidence shows that mesh repairs have lower recurrence rates than suture repairs, but there is no difference between the various mesh repairs and no difference between open and laparoscopic surgeries. There is very strong evidence that specialist hernia surgeons will have lower recurrence rates whatever technique they use. Chronic pain, defined as pain present 3 months after surgery, is common after all forms of surgery. It is less common and less severe after laparoscopic surgery. Different types of pain have been described, but the most severe is neuralgic pain due to nerve irritation. This may be the result of nerve injury at the time of the operation or chronic irritation of nerves by suture material or mesh. Careful identification and protection of all 3 nerves passing along the inguinal canal reduces the incidence of neuralgic pain. This type of pain is also very uncommon after laparoscopic surgery that is performed at a deeper level away from the nerves. Some contribution to chronic pain may be due to the mesh. which can become embedded in a dense collagenous reaction with shrinkage. This causes tissue tension and rigidity. Rarely, damage to the testicular artery can lead to testicular infarction, perhaps the most serious complication of inguinal hernia surgery. There is no good evidence that hernia surgery has an effect on male fertility, despite extensive study in this area. Complications: early pain, bleeding, urinary retention, anesthetic related, medium seroma, wound infection, late chronic pain, and testicular atrophy. Now, what is sportsman hernia? This specific entity is well described and persists as severe pain in the groin area extending into the scrotum and upper thigh. It is almost entirely restricted to the young men who play contact sports such as football and rugby. The pain can be debilitating and prevent the patient from exercising. On examination, there may be some tenderness in the region of the inguinal canal, over the pubic tubercle, and over the insertion of the thigh adductor muscle. Usually no hernia can be felt, and only occasionally can a true inguinal hernia be found. In most cases, the pain is due to an orthopedic injury such as adductor strain or pubic symphysis diastasis. However, some believe that it can be due to muscle tearing, Gilmore's groin, or stretching of the posterior wall of the inguinal canal. Other causes of pain should be excluded, such as hip, pelvic or lumbar spinal disease and bladder or prostate problems. MRI is most likely to detect an orthopedic problem, but ultrasonography, herniography or even laparoscopy may be used. There are many anecdotal reports of successful treatment using all types of inguinal hernia surgery, suture and mesh, open and laparoscopic, but no randomized trials. Hernia surgery should be a last sort and the patient warned of a significant risk of failure to cure the pain. Now, femoral hernia, basic anatomy: the iliac artery and vein pass below the inguinal ligament to become the femoral vessels in the leg. The vein lies medially and the artery just lateral to the artery with the femoral nerve lateral to the artery. They are enclosed in fibrous sheath. Just medial to the vein is a small space containing fat and some lymphatic tissue, node of Cloquet. It is this space which is exploited by a femoral hernia. The walls of a femoral hernia are the femoral vein laterally, the inguinal ligament anteriorly, the pelvic bone covered by the iliopectineal ligament Astae Cooper's posteriorly, and the lacunar ligament Gimbonats medially. This is a strong curved ligament with a sharp unyielding edge that impedes reduction of a femoral hernia. 60.20. In the 60.20 we can see the right femoral hernia. Laparoscopic view: the slightly oblique inguinal ligament can be seen superolaterally above the defect. The external iliac vein is not seen. A, inguinal ligament, then B is the lacunar ligament, C is the arch of the pubic bone, and D, fatty tissue overlying the iliac vessels. In female pelvis, has a different shape to the male, increasing the size of the femoral canal and the risk of hernia. In old age, the femoral defect increases and femoral hernia is commonly seen in low weight elderly women. There is a substantial risk of developing femoral hernia after a sutured inguinal hernia repair. Denmark hernia registry. Femoral hernia summary 60.11, less common than inguinal hernia. It is more common in women than men. Easily missed on examination. Of cases, 50% present as an emergency with very high risk of strangulation. Diagnosis of femoral hernia: diagnostic error is common and often leads to a delay in diagnosis and treatment. The hernia appears below and lateral to the pubic tubercle and lies in the upper leg rather than in the lower abdomen. Inadequate exposure of this area during a routine examination leads to failure to detect the hernia. The hernia often rapidly becomes irreducible and loses any cuff impulse due to the tightness of the neck. It may only be 1 to 2 cm in size and can easily be mistaken for a lymph node. As it increases in size, it is reflected superiorly and becomes difficult to distinguish from a medial direct hernia, which arises only a few centimeters above the femoral canal. Direct inguinal hernia leaves the abdominal cavity just above the inguinal ligament and a femoral hernia just below it. Figure 60.21, the patient with a left femoral and a right inguinal hernia. We can see the difference of the levels. It's just below the inguinal ligament, this is just above the inguinal ligament. Differential diagnosis: direct inguinal hernia, lymph node, saphenomatics, femoral artery aneurysm, psoas abscess, rupture of adductor longus with hematoma. Investigations: what are the investigations to be done? In routine cases, no specific investigations are required. However, if there is uncertainty, then ultrasonography or CT should be requested. In the emergency, patient Bowel obstruction usually occurs and a plain radiograph is likely to show small bowel obstruction. All patients with unexplained small bowel obstruction should undergo careful examination for a femoral hernia. It is now common to perform CT scanning in cases of bowel obstruction primarily to exclude malignancy, but it can identify any obstructing femoral hernia missed by clinicians. Surgery for femoral hernia. There is no alternative to surgery for femoral hernia, and it is wise to treat such cases with some urgency. There are 3 open approaches, and appropriate cases can be managed laparoscopically. Now there is low approach, that's given by Lockwood or known as Lockwood. This is the simplest operation for a femoral hernia but suitable only when there is no risk of bowel resection. It can easily be performed under local anesthesia or transverse incision is made over the hernia. The sac of the hernia is opened and its contents reduced. The sac is also reduced and a non-observable suture are placed between the inguinal ligament above and the fascia overlying the bone below. A small incision can be made in the medial lacunar ligament to aid reduction, but there may be an abnormal branch of the obturator artery just deep to it which can bleed. The femoral vein lateral to the hernia needs to be protected. Some surgeons place a mesh plug into the hernia defect for further reinforcement. Then there is the inguinal approach, which is given by Lothessin or known as Lothessin. The initial incision is identical to that of Basni's or Lichtenstein's operation into the inguinal canal. The spermatic cord or round ligament is mobilized and the transversalis fascia opened from deep inguinal ring to the pubic tubercle. A femoral hernia lies immediately below this incision and can be reduced by a combination of pulling from above and pushing from below. If necessary, the peritoneum can be opened to help with reduction. Once reduced, the neck of the hernia is closed with sutures or a mesh plug, protecting the iliac vein throughout. The layers are closed as for inguinal hernia, and the surgeon may place a mesh into the inguinal canal to protect against development of an inguinal hernia. Some surgeons believe that exploration of the femoral canal to exclude a hernia should be a routine part of inguinal hernia surgery, but most surgeons do not do this. Then there is a high approach. We saw the lower approach, then the inguinal approach, and now the high approach given by McEvedy. This more complex operation is ideal in the emergency situation where the risk of bowel strangulation is high. It requires regional or general anesthesia or horizontal incision, classically vertical, is made in the lower abdomen, centered at the lateral edge of the rectus muscle. The anterior rectus sheath is incised and the rectus muscle displaced medially. The surgeon proceeds deep to the muscle in the pre-peritoneal space. The femoral hernia is reduced and the sac opened to allow careful inspection of the bowel and a decision made regarding the need for bowel resection. This is performed if necessary. In dubious cases, the bowel is placed into the peritoneal cavity for 5 minutes and then re-examined. The femoral defect is then closed with sutures, mesh or plug. This approach allows a generous incision to be made in the peritoneum which aids inspection of the bowel and facilitates bowel dissection. Now, laparoscopic approach, both the total extraperitoneal and the transabdominal preperitoneal approach can be used for a femoral hernia and standard mesh inserted. This is ideal for reducible femoral hernias presenting electively but not for emergency cases or irreducible hernias. Ventral hernia. This term refers to the hernias of the anterior abdominal wall. Inguinal and femoral hernias are not included even though they are ventral. Lumbar hernia is included despite being dorsolateral. The European Hernia Society classification distinguished primary ventral hernia from incisional hernia but did not include parastomal hernia. We have included parastomal hernia and traumatic hernia over here. Then ventral hernias, umbilical, paraumbilical, epigastric, incisional, parastomal, spigelian, lumbar and traumatic. Umbilical hernia. The umbilical hernia is present at birth but closes as the stump of the umbilical cord heals. Usually within a week of birth, this process may be delayed, leading to the development of herniation in the neonatal period. The umbilical ring may also stretch and reopen in adult life. Umbilical hernia in children. This is common condition, occurs in up to 10% of infants with a high incidence in premature babies. The hernia appears within a few weeks of birth and is often symptomless but increases in size on crying and assumes a classic conical shape. Sexes are equally affected, but the incidence in black infants is up to 8 times higher than in whites. Obstruction and or strangulation is extremely uncommon below the age of 3 years. Treatment. Conservative treatment is indicated under the age of 2 years when the hernia is symptomless. Parental reassurance is all that is necessary. Of hernias, 95% will resolve spontaneously. If the hernia persists beyond the age of 2 years, it is unlikely to resolve and surgical repair is indicated. Surgery. A small curved incision is made immediately below the umbilicus. the neck of the sac is defined, opened, and any contents are returned into the peritoneal cavity. The sac is closed and the redundant sac is excised. The defect is the linea alba is closed with interrupted sutures. Now, umbilical hernia in children, common in infants and mostly resolve spontaneously, rarely strangulate. Umbilical hernia in adults. Conditions that cause stretching and thinning of the midline raphe, linea alba, such as pregnancy, obesity, and liver disease with cirrhosis, predispose to reopening of the umbilical defect. In adults, the defect in the median raphe is immediately adjacent to, most often above, the true umbilicus. Although at operation, this is indistinguishable. The term paraumbilical hernia is commonly used. The defect is rounded with a well-defined fibrous margin. Small umbilical hernias often contain extraperitoneal fat or omentum. Larger hernias can contain small or large bowel, but even when very large, the neck of the sac is narrow compared with the volume of its contents. As a result, in adults, umbilical hernias that include bowel are prone to become irreducible, obstructed, and strangulated. Clinical features. Patients are commonly overweight with a thinned and attenuated midline raphe. The bulge is typically slightly to one side of the umbilical depression, creating a crescent shape appearance to the umbilicus. This crescent shape is shown 60.22. You can see the crescent shape appearance. A small paraumbilical hernia is shown. Women are affected more than men. Most patients complain of pain due to tissue tension or symptoms of intermittent bowel obstruction. In large hernias, the overlying skin may become thinned, stretched, and develop dermatitis. Treatment. As a result of high risk of strangulation, surgery should be advised in cases where the hernia contains bowel. Small hernias may be left alone if they are asymptomatic, but they may enlarge and require surgery at a later date. Surgery may be performed open or laparoscopically. Open umbilical hernia repair. Very small defects less than 1 cm in size may be closed with a simple figure of 8 suture or repaired by a Tarn technique, which is non-absorbable monofilament suture in crisscrossed across the defect and anchored firmly to the fascia all around. Defects up to 2 cm in diameter may be sutured primarily with minimal tension. Although the larger the defect, the more tension and the more likely it is that mesh reinforcement will be beneficial. The classic repair was described by Mayo. A transverse incision is made and the hernia sac dissected, opened, and content reduced. Any non-viable tissue is removed, sometimes involving bowel resection. The peritoneum is closed. The defect in the anterior rectus sheath is extended laterally on both sides and elevated to create an upper and lower flap. The lower flap is then inserted beneath the upper flap and sutured to it, with the upper flap being brought downward over it so that the tissue is two-layered, double-breasted. Non-absorbable sutures are used. There is often a large subcutaneous space. A suction drain is placed to reduce the risk of seroma and hematoma. The skin is closed but stretched and redundant skin may need to be excised. Apronectomy. To achieve a better cosmetic result, today with modern suture materials, surgeons simply close the anterior sheath in a single layer. The defects. Now for the defects larger than 2 cm in diameter, mesh repair is recommended. Figure 60.23 we can see massive paraumbilical hernia. This is the operative view, and figure 60.24 we can see paraumbilical hernia. This is the laparoscopic from inside. Okay, the mesh can be placed in one of the several anatomical planes. Within the peritoneal cavity, a tissue separating mesh is placed through the defect and spread out on the underside of the abdominal wall and fixed to it, ideally with an overlap of 5 cm in each direction. This is a quick repair but requires the use of expensive mesh. In the retromuscular space, the linea alba is opened vertically and both left and right posterior rectus sheaths are incised 1 cm to the side of the midline, exposing the rectus muscle. The posterior sheaths are sutured together and the muscles elevated away from the sheath to develop the retromuscular space, into which a sheath of mesh is placed and fixed by sutures. The mesh should overlap the midline by 5 cm laterally and umbilicus vertically. It should therefore be a minimum diameter of 10 cm. A drain may be placed deep to the linea alba. This is a very secure repair but requires extensive dissection. In the extraperitoneal space, it is difficult but possible to develop the plane below the posterior rectus sheath just outside the peritoneum. Care must be taken to avoid buttonholing the peritoneum because it is thin and fragile. Mesh can be mesh can then be tucked into this space, ensuring a good overlap as before. Ideally, the linea alba is closed over the mesh, but if this is not possible, a flap of peritoneal sac can be used to cover the mesh. This is a good repair, but if the peritoneum is extensively damaged during this dissection, it will have to be abandoned in favor of an alternative technique. The subcutaneous plane. This is the simplest technique called an onlay mesh. The peritoneal sac and the contents are dealt with as above. An attempt is made to close linea alba vertically with sutures, and a disc of mesh is placed on the anterior rectus sheath and sutured to it. The mesh is lying in a subcutaneous space and is prone to infection. Coming to laparoscopic umbilical hernia repair, 3 ports are placed laterally to the abdominal wall, usually on the left side unless adhesions from previous surgery are likely. The content of the hernia are reduced by traction and external pressure. The falciform ligament above and the median umbilical fold below may need to be taken down if they interfere with the mesh placement. A disc of non-adherent mesh designed for intraperitoneal use is introduced and transpositioned on the udder surface of the abdominal wall, centered on the defect. It is then fixed to the peritoneum and posterior rectus sheath using staples, tacks or sutures. This is a simple and secure repair which achieves generous overlap without surgical damage to umbilicus and surrounding fascia. However, it requires specialized equipment and expensive tissue separating mesh. Intraperitoneal meshes can cause severe pain lasting for 24 to 48 hours after surgery, which can mimic peritonitis. Emergency repair of umbilical hernia. Incarcerated bowel obstruction and strangulation are frequent because of the narrow neck and the fibrous edge of the defect in the midline raphe. Delay to surgery can lead to gangrene of the omentum or bowel. Large hernias are often multiloculated and there may be strangulated bowel in one component when other areas are clinically soft and are non-tender hernia. Surgery in cases of simple incarceration without clinical evidence of strangulation. Repair may be attempted laparoscopically, but reduction of the contents can be very difficult if the hernia contains bowel. Most emergency repairs are performed by open surgery. In the presence of established strangulation, it is unwise to place mesh at all because the risk of infection, so an open sutured repair should be performed, accepting a high risk of later recurrence. Alternatively, a 2-stage repair could be planned, the hernia contents being dealt with initially with little attempt made to close the defect, and then subsequent definitive mesh repair once sepsis has been controlled.